Hola, ¿qué tal? Mi nombre es Luis Martínez y me da mucho gusto darles la bienvenida a esta nueva plática con líderes en salud global. En esta ocasión tenemos la oportunidad de platicar con la doctora Joia Mukherjee, quien es una de las más grandes exponentes en el tema de la salud global y medicina social. Me gustaría tomar unos minutos para presentar a nuestra invitada del día de hoy. Joia Mukherjee es una doctora especialista en medicina interna y pediatría con enfoque en atención de enfermedades infecciosas, con gran trayectoria académica. La doctora Mukherjee es profesora asociada de medicina en la División de Equidad en Salud Global en el Hospital Brigham en Boston y es profesora asociada de Salud Global y Medicina Social en la Facultad de Medicina de Harvard. En esta prestigiosa universidad, la doctora Mukherjee dirige el programa de Maestría en Ciencias Médicas en Salud Global y además imparte clases enfocadas en enfermedades infecciosas y otros cursos relacionados a la implementación de salud global y derechos humanos. Todo esto dirigido a profesionales de la salud y estudiantes en todo el mundo. Además, Joia Mukherjee ha sido coordinadora médica de Partners in Health, una organización médica sin fines de lucro que se enfoca en reducir la disparidad en salud, fortaleciendo los sistemas de salud a través del apoyo del sector público y desarrollando programas basados en la comunidad. Además, es autora del libro Introduction to Global Health Delivery, Practice, Equity, Human Rights. Dr. Mukherjee, hi, how are you today?
I'm fine, Luis. How are you?
I'm fine, thank you. And thank you for giving us some minutes of your time to talk about global health and social justice.
Great.
Professor, can you tell us, just to begin with this interview, a little about yourself? Who is Joia Mukherjee and how did you start your career in global health?
Yes, well, thank you so much, Luis. So I am an American. I'm the daughter of an immigrant father from India and a mom who's a white American from Chicago. I grew up with a lot of privilege. My parents were both college professors. But I think some of my worldview was shaped by visiting India, my dad's home country, in the 1970s, when there was just the ending of the war between Bangladesh and Pakistan, and many refugees living in the streets of my dad's home city of Calcutta. And really seeing that my own privilege of living as a white-seeming, though biracial person, in the setting of plenty of food and housing, was living somehow on the same world as children my own age, I was 8 at the time, who were begging on the streets, who were caring for smaller children because their parents had died. And I think that experience really opened my eyes to inequality and really put me on a path to really search as to why this could happen in a world with so much wealth, as to what my positionality of privilege could contribute to remediating some of this inequality. Deep thoughts for an 8-year-old, so I was like kind of a weird, nerdy kid. And then when I got to college, the AIDS epidemic was just starting, and it seemed rapidly to be obvious that this would be an epidemic that would define whose lives mattered and whose didn't from a worldview, whether it was people who were considered minoritized by their sexual preference, or people who were racially minoritized in sub-Saharan Africa, or because of substance use. And so that is sort of how I started really through this avenue of the AIDS epidemic, sort of opening rents in the fabric of already vulnerable people's lives.
Yeah, of course. The concepts of global health and social justice indeed have become more important in recent years, in particular after AIDS. However, these concepts are not well understood in our region. in particular in Latin America and Mexico. I would like to use this that you're talking about this. How do you define the concepts of global health and social justice, and why these concepts are important to be understood for young health professionals right now?
Thank you, Luis. You know, I would say that I've learned a lot about social justice from Latin America. So while these concepts may not be understood in our profession, in the medical profession, they are well understood by the poor. And there are a lot of progressive social movements in Latin America, including the Latin American, social medicine, ALAMES group, where if we don't, when we look at health disparities, they are not caused by a virus or a bacteria. They are not caused by a gene. They are not caused by behaviors that are chosen. Health disparities are really caused by an unequal access to the things that people need for their life, whether it's food, housing security, water and sanitation, access to a medical system that can provide good quality care. And so I think, again, our profession may not be so aware anywhere in the world, but I think if we align ourselves with the needs of the poor people, the voices of people who are poor and otherwise oppressed, that is a clear map for us on how social justice needs to happen, which is often, justice is fundamentally a retrospective concept. You have to understand that something is wrong to then have a right be done in its stead. So a lot of the wrongs that have been done in terms of who owns land, who gets a particular education or a job, those then get into the body as illnesses. And so when we think of health and social justice together, it's realizing those historical and present day wrongs and materially resourcing the poorest and sickest people for what they need. And we saw that a lot during COVID in the United States, where my organization, Partners in Health, was asked to help. We did the contact tracing. We did inform people of their status. But the equity piece was to say, can you isolate? Can you quarantine? And if the answer was no, then we said, what do you need to make that happen? Is it groceries? Is it help to not be evicted from your house? Is it diapers for your baby? And that's the equity proposition. And recognizing that the injustice of people in a very wealthy country like the United States living without food or housing security is a product of historical injustice. So it is not just a charitable approach, but an approach that has underpinning language to understand those historical and political wrongs.
Yeah, thank you, Professor. Just continue with this idea. What do you think are the biggest challenges that global health is facing today, and how can we address them, in particular after COVID-19?
Mm-hmm. So, the biggest challenge is the idea that we can't do better, the failure of imagination, the idea that we must have a handful of people making extraordinary profits. And if that doesn't trickle down, well, that's just too bad. We see that the companies that made the COVID vaccines, blockbuster profits. And the majority of the world, the poor world, did not get the vaccine. We see that people who are already poor became poorer because of global inflation. And so we've got to think about what are the basic human rights for everyone, not only based on the country in which they live, but based on some universal notion of who matters. And, the historic oppression of, people of color, Black people, brown people, indigenous people, poor people who are white, that has shown us its face in COVID, who died of COVID. That has shown us again its face in who dies of HIV. And so we have to recognize that Our big challenge is to see all of our brothers and sisters as equally human, as equally needing support, and those who are impoverished or otherwise oppressed needing actually more support. And at Partners in Health, we call that preferential option for the poor. In other words, putting more resources toward people who are suffering from much more dire health consequences as a result of their social position in the world. So I think that's our biggest challenge. And we have to recognize that we have to have a sense of all being together in this. And climate change is our biggest test, because we are going to see the impact disproportionately, we already do, on poor communities, and the utilization of, and putting carbon in the atmosphere coming from rich communities. And it is time that we recognize that we're all, we are all responsible for taking care of one another. And some of us, the rich world, bears more responsibility and needs to put more resources to protect others.
Thank you, Professor. Now that we are talking about also partners in health, I would like to address two questions. But the first one perhaps is one of the most important. One of the greatest advocates and champions of global health was Dr. Paul Farmer, and with whom you had the opportunity to work for many years at Harvard and Partners in Health. What do you think has been Paul Farmer's legacy for global health?
Yeah. So Paul's legacy was this creation of a movement of people who believed in the practice, the analysis, and really the championing of social medicine. When I was a young student, and Paul's work was not so in the spotlight, we were always taught that, people need to change their behavior, prevention is better than cure, without interrogating the social forces that made people sick, prevented them from getting care. And so everything was, a person's individual responsibility and behavior. And Paul's vast scholarship in anthropology, in health, really outlined a different path, which is that the structural forces, the structural violence, not only are causal rather than the behaviors of an individual person, but are remediable. That's the hopeful part. If you give people food along with their TB treatment, they will do very well. If you can give a mother whose child has malnutrition, if you can give that mother a job as well as treating the child, then her remaining children will be much healthier. And so Paul's analysis of the world really was a different path for many of us who didn't want to continue to blame the poor for their suffering, but wanted to interrogate these social forces, but not only to be an armchair critic, but to do something about it. And, as a very generative person, Paul taught so many of us, myself included, about how to do that analysis, how to be proximate to the patients, and then how to take that energy that we get from really knowing the truth and act on it. And there are thousands and thousands of people around the world who have learned that. And that is really Paul's legacy, is the analysis and practice of social medicine.
Thank you, Professor. And just before ending, many of our viewers are young health professionals, and mainly from the region, Mexico, and countries in Latin America. What message would you like to give them today?
Well, I would say Latin America has been a shining star in many ways for social medicine. And there is a lot of progressive thought in Latin America that can be and should be linked to our profession. When you look at liberation theology, which was something extremely important to Paul Farmer, that came from Peru and Gustavo Gutierrez. When you look at the Freirean pedagogy, which is about trying to have shared mastery, which with each and every person we're working with, from a peasant farmer to a high minister. That comes from Brazil and from the work of Paulo Freire. If you read The Open Veins of Latin America, that comes from Eduardo Galeano. There is a lot of very progressive thought. So, and then there is the incredible group of the social medicine, consortium in Latin America, ALAMES. So I would say lean into our history, our regional history in Latin America, and to the scholars that came before us and that still exist, that are really writing and thinking and trying to act on very progressive thought, to try to remediate suffering and also understand the historic roots of that.
Fantastic, Professor. Dr. Mukherjee, thank you one more time for giving us this space today. Please receive from all the team of the Mexican Society of Public Health and our best wishes for you, for your family, and your team at Harvard and Partners in Health. Thank you so much, Professor.
Thank you, Luis. Okay, nice to see you.
Nice to see you.